Hello, and welcome to our audience today. My name is Lacey Ahern. I'm the Program Director for Global Partners in Care, which is a US-based organization that supports access to hospice and palliative care worldwide, focusing on building collaborative partnerships and advancing research and educational opportunities in global palliative care. I'm also an adjunct assistant professor of the practice here at Notre Dame. I previously was here full-time for about 10 years and have engaged with global health at Notre Dame for quite some time. So I have an interesting experience of working at the university level in global health, but also working with grassroots organizations and those even at the national level to implement global health programs. So the discussion on compassion in our field of global health has become increasingly important to me in my work in palliative care. Palliative care is often referred to as compassionate care, and the language of compassion is not foreign to the field of hospice and palliative care. So it is unique that I see it from that perspective now, yet in much of my other global health work, the term of compassion and compassion language is not common. So why is that? That's something we want to discuss more today. And I think it's particularly important. We are talking about this in a university setting where we are training future global health leaders. It's important that we talk about compassion, not only in our work, but for ourselves as well. Our own Father Ted Hesburgh was fond of saying that you cannot create peace in the world if you are not at peace with yourself. And we all know that this past year has posed incredible new challenges to our health and well-being. The COVID-19 pandemic has ravaged our world. It's uncovered and exacerbated health inequalities, and we have all been touched in some way by this pandemic. I personally have struggled to find peace and self-care during this time, but we need to do so when we are fighting inequities in health. Just as Father Ted said with peace, we cannot awaken compassion in the world if we are not paying attention to self-compassion. So we have an excellent group of people today with us who will be talking about health equity and compassion in global health. This amazing group of people came together last year as part of a course we took with the Center for Compassionate Leadership. This course provided an opportunity for us to discuss compassion openly and compassionate leadership, including the very important topic of self-compassion. It catalyzed not only this group of speakers, but I think our entire cohort to think more deeply about compassion in our global health work. So we want to thank in a special way Laura Berland and Evan Harrell, who facilitated that course. They supported this burgeoning community of compassion revolutionaries, and I encourage all of you to learn more about the Center for Compassionate Leadership. Now, for our discussion today, we want this to be as interactive as possible, as a webinar can be. In the first part of the webinar, our panelists will share their thoughts on compassion and global health, and then we will move into more of a discussion and we'll take questions from the audience. So please, throughout the webinar, put your questions in the Q&A box, and we will try to get to as many of those as possible. Finally, I'd like to introduce Bruce Compton. Bruce will be moderating this discussion with me today. Bruce is a Senior Director of Global Health for the Catholic Health Association of the United States. He is responsible for assisting and supporting CHA member organizations in their outreach activities globally. He facilitates collaboration among member organizations, seeking to enhance the impact of their international ministries. He also represents CHA in a number of global health coalitions, including those around water, sanitation, and hygiene, mapping faith-based health facilities, supply chains in low and middle income countries, leadership and management capacity building, appropriate short-term engagements in global health, and this evolving coalition of compassion in global health. These coalitions are made up of multiple partners, including NGOs, universities, corporations, faith-based organizations, and others. And I want to make a special note on the importance of coalitions, partnerships, alliances. Nothing we do, especially in global health, happens alone. We are in this together. We need to work together, support each other, and compassion is a necessary ingredient for this work. So with that, I will turn it over to you, Bruce.
Thank you so much, Lacey. And thank you to the University of Notre Dame Eck Institute, the Catholic Health Association, and the Task Force for Global Health's focus area on compassion and ethics for co-sponsoring this. I'd like to start with something I didn't ask permission to do, but if everybody just maybe type into the chat box where you have experience in global health, just so that we can start to get to know who we have with us. But before, so while you're doing that, let me take a moment to introduce Lacey, who was very humble in her introduction of herself. Lacey has 18 years of experience working in international health and development, with a focus on program development and community engagement for not-for-profit organizations. Lacey served on the Global Health Curriculum Committee for the Consortium of Universities of Global Health and was instrumental in building global health training programs at Notre Dame. She has worked with numerous students over the years on research projects related to public health globally and locally. Her international work includes time living and working in East Africa with the United Nations, the Congregation of Holy Cross, Uganda Martyrs University, and other local organizations. As she said, her current areas of focus on palliative care and the role of partnerships are perfect for this conversation on compassion. So as Lacey said, I'm Bruce Compton. I'm the Senior Director for Global Health at the Catholic Health Association of the United States, where one of our taglines on every webpage is a passionate voice for compassionate care. So this is an important topic for CHA. And Lacey mentioned the Center for Compassionate Leadership, and the cohort that we took part in last fall was an amazing opportunity for us all to learn about how others engage compassion and to really engage this question, do we need a compassion revolution? I believe that if we're truly compassionate, as you'll hear from our speakers, we are talking about health equity. We're talking about justice. We're talking about true compassion. I want to give a brief example. It's not a great example in one way, but it is a great example on the other hand. And that is, I was on a conversation last week about clean water, sanitation, and hygiene in healthcare facilities. And there were a lot of really important people on this call. It was extremely well organized. And we talked about clean water and how that was such an important aspect to the basics of health. And after 30 minutes of the conversation, a doctor from America who was acting out of love and hope and help for others really took it a different direction and said, well, this really needs to be research-based. And she said, we have done the research, and dirty water is better than no water at all. When our conversation wasn't about whether we wanted dirty water, it was about getting clean water. It was about that equity, that justice, and that true compassion for our brothers and sisters around the world. So this is an extremely important topic, as you'll hear again from the three presenters. So let me take a moment to introduce them. We have with us today Dr. Syed, Head of Unit for Quality of Care at the World Health Organization. Sedem Adiabu, a graduate student at the Rollins School of Public Health at Emory University. And our first speaker today will be Dr. David Addiss, Director of the Focus Area for Compassion and Ethics at the Task Force for Global Health. David has held many positions at the task force, was a senior program officer at the Science and Spirituality program at the Fetzer Institute, Spent 20 years at the Centers for Disease Control and Prevention, where he conducted research on the prevention and control of parasitic diseases. And I met David when he was an adjunct professor at the University of Notre Dame, working with the Eck Institute. I have tried to keep up with all of his great work ever since, and I would like to welcome David Addiss. And David, if you could just fill in any gaps that you think are important, begin to talk about why you believe compassion in global health is important, especially what your experience in your positions has led you to believe that there is this need for a compassion revolution. David, the floor is yours, and thank you for being here with us.
Thank you very much, Bruce. It's really a pleasure to be here with my panelists and with all of you today. For several years, I've been curious about this gap between what motivates so many of us in global health, which in quiet moments is expressed in terms of care or compassion or love, but we don't use these words in our discourse. There's a gap, there's an absence of this language, as Lacey mentioned, in our collective discourse. Lacey, if I could have the next slide, please. It might be helpful to share a few foundational principles about compassion to start our conversation today. Social psychology teaches that compassion is made up of 3 elements. Some typologies have 4 or 5 elements, but basically these boil down to 3 things. You have to be aware of suffering. There's a cognitive attunement in order to respond to it with compassion. So there's an awareness, a cognitive element of compassion. We have to be aware of suffering and recognize it as suffering. So in that sense, compassion is a response to suffering. Then there's empathy, which is the emotional attunement, in a sense, feeling the pain of the other person. And finally, there's the action, or at the least, the desire to act. And in some situations, this may be a very subtle action. It may be presence, as Lacey mentioned in palliative care, just one's presence is compassionate. In other situations, it might mean launching a big program to reduce health disparities or health suffering. The next slide, please. We have several challenges to compassion in global health. Neurologically, sort of psychically, we're wired to respond to suffering at the individual level. But in global health, we also work with populations, and we sometimes struggle with the signals of compassion, of suffering that are coming into us. We deal with numbers and graphs and figures rather than the face of the individual person. We also work in complex bureaucracies, and sometimes our bureaucracies get in the way of the compassionate impulse, or they certainly complicate it. And then we also have the challenge of sometimes the agencies that we work for are at times have values or positions or policies that are in tension with compassion. We're often driven by economic or political or military interests rather than by compassion. Next slide, please. I think it might be helpful for our discussion to view compassion and a response to suffering as a spectrum. On the one hand, there's cruelty, the opposite of mature compassion. And on the other end of the spectrum, there's mature compassion. Cruelty can be seen as a far enemy of mature compassion. But there are other near enemies, such as pity. Mature compassion is rooted in solidarity, respect, and a profound awareness of our human interconnectedness, while pity is often an expression of condescension or of superiority. The French philosopher Didier Fassin is referring to pity when he says that compassion presupposes a relation of inequality. It's directed from above to below, from the more powerful to the more vulnerable. This is pity rather than mature compassion. I believe that the answer is not to strip compassion from our vocabulary, our programs, and our global health discourse, but rather to make it more mature and more grounded in solidarity. To me, this transformation to a mature compassion requires inner work at the individual level. Some might call this spiritual work. It requires collective conversation, such as the one we're having today about our shared values. And it also requires systemic change. And in a sense, all three of these together, I believe, constitute a compassion revolution. Thank you for the opportunity to share these initial thoughts, and I'm looking forward to our time together for conversation.
Thank you, David. That is a great start. Really appreciate that. And we will get back to you with some of the other questions. I would now like to introduce Sedem Adiabu. Sedem is, as I said, is a graduate student studying here in the United States at the Rollins School of Public Health at Emory University. She's a global health student originally from Ghana, studying community health and development. Sedem's interest in compassion and ethics emerged from her desire to connect the interactions among public health practitioners and the needs of the community served. Sedem brings a unique perspective as a trainee and as someone with a perspective from a low and middle income country. Welcome, Sedem. The floor is yours.
Thank you so much for that introduction, Bruce. I'm going to start by giving us a brief history about the foundations of global health. And in order to understand what decolonization is all about and how it relates to compassion, I invite you all to travel with me back in time to the beginning markings of European conquest. Now, colonial medicine was not only a tool to facilitate colonial expansion, but it established structures to protect the health and economic interests of colonizers, which set up extractive states. And then around the 1960s, we start to see this term of international health, which came around the time where nations started to gain independence from colonial rule. And international health is mostly focused on preventing the spread of disease to the Western world. It was approached from a them versus us. And now we enter in the 2000s, the early 2000s, a time where we term now global health is focused on improving health and achieving health equity for all populations worldwide. And it relies mostly on collaborations and partnerships, where we see global agenda setting and decision-making from multiple stakeholders and actors, both nationally and internationally. Please advance to the next slide. And so before we jump into the relationship between decolonizing global health and compassion, I want to discuss the rationale for decolonization, as sometimes it's not really clear. So the central paradigm and guiding principle for global health activities is global health ethics, which places human rights and moral values at the core of its operations. And so given our history of global health and the function of colonialism, it is our duty to understand how this foundation manifests in global health culture today, and how we might want to make some infrastructural changes to safeguard the future of health for people worldwide. And as David so eloquently laid out for us, compassion is sort of the methods, if you will. It is comprised of awareness, a motivation or an empathy, and an action. And so an awareness that we all share a common mission that is signified by our humanity, being able to recognize suffering along with the motivation to want to do something, as well as then finally taking that action, having the courage to, in fact, do something about it. And now we can apply this lens to decolonization. And decolonization is having that awareness that global health was birthed from profound harms, both intentional and unintentional, and its impact is still being felt today. So widespread understanding of the impact of colonialism on the health of formerly colonized countries is needed. A revolution would involve a re-education and interrogation of our assumptions and the critical understanding of the most important social determinant of health, colonialism. And if you remember, I talked a bit about global health relying on partnerships and collaborations. Yet operationally, we still see some unequal power dynamics between high-income countries and lower middle-income countries. And this is determined by a Western-dominated system, which influences decision-making, global health funding streams, it influences accountability, it determines resource allocation, research and knowledge production, authorship, and mainstream narratives about developing countries, just to name a few. A common example used in global health is the case of malaria and global response to malaria through the distribution of insecticide-treated bed nets, and resulting in some communities using those bed nets for fishing rather than its intended use. And this case was instructive for two reasons. One, because as a global health community, we failed to recognize that people don't really care about their health when they can't meet their basic needs. And second, we failed to include these intended beneficiaries from the beginning research planning stages of the intervention. And so as Loretta Ross famously says, there's no such thing as a single issue struggle because we do not live single issue lives. And this was a classic example of what happens when decisions are made without consulting the people affected by the decision. And so we have to understand the capacity of people in order to meet them where they are. In recognizing our interconnectedness, there's an African saying in Bantu philosophy that says, I am because you are. We live in a cause and effect world. And this pandemic, if anything, has demonstrated that we are more interconnected than we would like to think. Decisions made from the global north will affect the global south and vice versa. We can no longer make decisions and live in silos because our future relies on this. In global health terms, it starts with individual level behavior change, a human revolution, if you will. You need self-compassion to be able to have compassion for others and to be able to be moved to contribute to the treasure of protecting humanity. This will be reflected in our immediate environments through work culture, organizational cultures, and narratives about different people that may not look like us. And this requires meaningful change. Meaningful change sometimes means a disruption of norms and assumptions. And a fundamental paradigm shift in global health would involve a transformation of our value system. Please advance to the next slide. It would involve one that respects human dignity and adopts a global perspective, allowing communities and populations who have previously had their contributions undermined to fully participate in decision-making. And so now it appears that our model is inherently flawed because we built an industry off the basis of injustice and expected it to transition from colonial medicine to health equity without much change to the systems that perpetuated that injustice. But we have a window of opportunity. And I'm happy to tell you that we all have something to do. We have a role to play. So it starts with developing a greater awareness. And education comes with the responsibility and understanding that we may not all have the answers. And we need to rely on other people who may not always be in power or have influence. So global health students, what you can do, you can ask yourself, does your syllabus represent knowledge from the global community? Are you being exposed to research or interventions from a diverse collection of literature? And if you're not, I encourage you to find some and share it with your professors because professors need help too sometimes. And in healthcare industry, we can't expect healthcare providers to practice compassion when they went through a system, an education system that demoralized them. And then now on top of that, they're experiencing massive debt, understaffed, and overwork. And so we need to infect them with compassion so they can infect their patients with compassion. We need to do more advocacy work. Never underestimate the power of grassroots level work. We hold people accountable, but we also need to hold institutions accountable. And this can be done compassionately because more people are willing to listen in a place of compassion than a place of shame and blame. And finally, I would like to close with a quote from my personal mentor, and it reads, "Education is not simply the transmission of knowledge. It is not simply the development of talent. Education is the great enterprise of steadily and surely passing on the fullness of humanity from past to future." And that's all I have for you. Thank you.
Well, Sedem, thank you. That was not all, that was a lot. And I am sure that many of us who are on this call working in global health look forward to the energy and the real depth of thinking that you and your fellow students bring to this, the future of global health. It's now my honor to introduce Dr. Shams Syed. Shams is the unit head for quality of care within the Department of Integrated Health Services in the UHC and Life Course Division at the World Health Organization. One of the longest titles I've ever talked about. He is in the headquarters in Geneva, Switzerland. He also sees a range of work streams within that unit, including WHO's work on twinning partnerships for improvement, many of those with universities and hospital systems that work with partners overseas. Shams has much experience around the world, including both in the UK and the US, and he has worked directly with over 30 countries during his career. Welcome, Shams. We'd love to hear why your perspective, you think there's a need for a compassion revolution. And of course, you can fill in any holes that I left in your extensive bio. And I'll just close by saying this piece by saying, I don't even try and keep up with Shams. I see him a couple times a week on different presentations, but I know he's on hundreds of others. So Shams, thanks for all your great work.
Bruce, thank you so much and for that really kind introduction, and also just a big thank you to the organizers of this discussion. It's really wonderful to hear Sedem speak so passionately about compassion, and this is really something to be thinking about for the longer term, for the future, as we look back on the historical perspective that Sedem so nicely presented to us. I'm going to share a few thoughts and actually build on some of the points that David made. And if I can have my first slide. So first, if I may, just taking us back right to an individual. So numbers are numbers, right? But it is important to remind ourselves that in the world that we are living in today, that a 15-year-old girl, the probability that a 15-year-old girl that will eventually die from a maternal cause. And I'm not going to read these numbers out, but look at those numbers. Are we serious about equity when we think about a girl in Chad, 1 in 15, all the way to Japan, 1 in 16,700? Global average, 1 in 190, and averages, and this is exactly the point that I'd really like to emphasize, is that averages are exactly that, averages. And if we don't look into the differences that exist between countries, and most importantly also the differences that exist within countries, then we are doing a disservice to humanity. And this can be seen in various ways, and one can see this from a very technical perspective, but one can also see this from the technical lens of compassion as well. I was born in Bangladesh, and my son was born in the United States. I recognize, looking back at my own personal history and my lived experience, that my son may have had some serious issues, and his mother may have had some serious issues if that birth took place in my country of birth. That's to say that we are placed within a situation where we have that ability to soak in the experience and the risks that we face as human beings facing healthcare. Next slide. Today is World Health Day, and the theme is health equity, and our focus is building a fairer, healthier world. The whole point about having World Health Days, it's not just about saying something that sounds good and saying something that needs attention. It's about action and how we can prevent and how we can move towards a fairer and a safer world. We at the WHO are urging leaders to monitor health inequities and to ensure that all people are able to access quality health services when and where they need them. Next slide. Coming to our thinking on compassion, this is where I'd like to spend just a little bit of time. David very eloquently described the triple awareness, empathy, and action. And that compassion equation that I like to always emphasize is required at every level. And let me consider just a few of those levels on the right-hand side of this slide. So if we think about this awareness, empathy, and action triad at each of these levels, all the way from point of care to the global level, each of those levels has something where we really need to consider carefully. So at the point of care, many colleagues will have experiences of delivering care, but at that point of care, the question, if we are posing that question, are we aware, are we empathizing, and are we acting? That lens provides an opportunity for us to improve on ourselves. And this is something that we have already heard from both David and Sedem, is that the change starts with oneself. But at that point of care, how are we ensuring that each clinical interaction has compassion embedded within it? But of course, it's not just the interaction between a health worker and a patient receiving care. When we think about health workers, and we're in the International Year of Health and Care Workers, what's the interaction like between health workers within the environment that they're working in? COVID-19 has hit all countries hard, and for sure, the heroes of this of the situation, the health workers, they need the attention between themselves to be able to really focus in on compassion. And health facilities need to be able to change their thinking so that they are able to think through what compassion means at the health facility level. And this includes management, this includes the clinical side, but it also includes certain unsung heroes, such as cleaners, such as administrators. That's where the health facility functions, and compassion can be placed within that health facility environment. Often, we forget the district level because it's an unsung hero of health systems. But if we look at the unit of analysis as a district, those individuals that are organizing services for a population, can you imagine how those organization of those services would be different if awareness, empathy, and action was placed within it? At the national level, a lot of critique, a lot of responsibility for national leaders. But when national health leadership is setting strategic direction, by placing the lens of compassion within that national discourse and also setting strategic direction, that has an opportunity to reshape the national direction and the action that's required for health to be a reality. And the final point, at the global level, we've heard from both David and Sedem the importance of equalizing the power imbalance that exists within global health architecture. That might be a strong phrase to use, but within the global health architecture, we recognize that there is a need to shift, and there is a need for compassion to percolate that global health dialogue. And this has huge potential and huge implications on how we move forward with global health as a whole. And this is where the Sustainable Development Goals also comes in, because as we heard earlier, health is one aspect of overall development. And when one is hungry, health may not be the first priority for a community. When one recognizes that the next news that they'll be hearing is that of the village next to them being bombed, that point is not going to allow health to be the first priority in that individual or in that village or in that community's mind. So this is where we bring in the totality of development and justice to bring in the focus on compassion for health, which has ramifications, which has implications for development as a whole. Let me pause there and back to you, Bruce.
Thanks, Shams, again, for all those insights and the connections to our two previous speakers. I think this is the time for us to really start a conversation amongst the three of you. And we have a couple of questions that are in the Q&A, but I'd like to start. We asked you to talk about why you thought there needed to be a compassion revolution. And some of you got into a little of this, but given your differing backgrounds, what does a compassion revolution in global health look like from your current vantage point? So we have someone at WHO, someone practicing within NGOs, and we have a global health student. We'd love to hear your thoughts on that question. And Shams, if you could, yeah, there we go. Anyone want to take a first shot? So what does it look like to have a compassion revolution? I think Sedem, you got to a lot of that. But from your vantage point, David or Shams, any thoughts to add on to this?
Well, if I may, I'm happy to jump in here. For me, Bruce, the concept of compassion revolutionary comes in at every level. And when we think about a revolutionary, what are we talking about? Somebody that's able to consider the necessity for change and somebody that's able to activate that necessary change. So for me, it comes back to multi-level action in all those levels that we discussed just now, but also to emphasize that it's the self, and this is also what we heard from Sedem and David, it does come back to your own inner self and the work that's required in yourself to be able to also be a catalyst for that revolution. What I really wanted to emphasize related to compassion is that it's not soft. And that's the critique that we will always hear about compassion, is that why don't we tackle the hard stuff first and then come to issues such as compassion. If we can embed compassion within the architecture of global health, then it has the potential to change how we think about things and how we act about things. That's why I believe that compassion revolutionaries are a must. Thanks, Bruce.
Thank you. David, any insights?
Yeah, I would just second what Sham said and what Sedem articulated earlier. It really is about a change of heart and mind. And it involves not just the externalities and the program goals, but it involves how we view what is ours to do in the world and who we are. It involves a much broader and open conversation about our values and our willingness to see where we have not done well, where we've actually inflicted harm unwittingly. So it requires a level of maturity, of in a sense security, to be able to take on board the critiques like those of Didier Fassin and others, to be able to hear them and to not become defensive. We in global health, like many, put a lot of our identity on the line in our work. And so it makes us maybe defensive to hear criticism that we need to hear and take on board in order to mature ourselves, but also in order for our programs to deliver the types of benefits that we want for them.
That's great. Thank you so much. Sedem, if you would like to add anything to that, you're welcome to. And then as you complete that, we have a question specifically for you about your presentation. And it's from Parker Kaneen. I'm sorry, Parker, if I mispronounced your last name. He says, Sedem, you elaborate on decolonizing with compassion. You said it can be done without shame and blame, but there's certain, and they said there's certainly blame to go around, but how do you do it without blame? Again, if you want to add to how do you see it from your vantage point, I think you already elaborated a great deal on that, but and then that question itself on how do you do it without blaming, a little more in detail. Thank you.
Sure, thank you. And I'd like to start by saying compassion is no easy work. Practicing compassion takes every single moment of your time. You're easily provoked by people and the environment that you're in. And so practicing compassion, having that awareness to not react, but to respond is a lot of work. It's no soft skill there that people like to say. And so when we apply this into populations, people are the center of our global health work. We work with people and we are all humans. And now to be able to get people to move towards a common goal, we need to get what's in their hearts and what's inside. And so if we apply that to healthcare and providing quality healthcare, if this doctor is under so much duress and they have to, take care of a patient, but they're suffering inside, it's sometimes really hard to recognize the suffering of another when you're also suffering inside. And so that's why for me, a compassion revolution is necessary, because we have to put people at the center of our work. When it comes to the question that Parker, I believe, posed, yes, there is a way to do it without shaming people, but in terms of decolonization, we have to first understand. We have to have an awareness of the profound harms that have been caused. And the way that we're taught global health oftentimes is very much apolitical, ahistorical. It's like, oh, we're just going to forget about colonialism like it never happened. And we're going to talk about global health in the now. But we need to talk about the past in order to affect change for the future, because we don't want to continue with making these mistakes. For instance, we just recently declared racism as a public health emergency, and it took someone dying to be able to do that in the global health community. And that is not a reflection of a blame or a shame, but it's a reflection of something we need to be aware of, something that we need to actively keep close to our hearts as we plan these interventions, as we go into programs, as we do our research, because it's our responsibility. We chose to be in this profession. And so we have that duty to uphold.
Thank you so much for that response, Sedem. I think it's very well said. I have a little personal experience with that I'd like to just interject, which is I led 13 mission trips to Haiti after having spent exactly 1 week in Haiti on a really bad mission trip in retrospect. And I then, during that 13 times, I was very supportive of the organization in multiple ways by sending people and by sending products. Then I was asked to go down and work at that clinic in Haiti after 4 years. And it was then that I realized that I was to blame, and I had to, for some of the things that were going wrong, and I had to take ownership of that before I could make any changes. And I saw the chaos that having volunteers sometime created for our staff that was working year round. I saw the donations that came into containers that I unloaded that were useless in many cases, and caused us lots of time and energy, affected the environment because they were shipped over on shipping containers and then shipped to us on trucks. So lots of that. Of course, it feels like there's blame, because there is blame, but it's really taking accountability for our actions. Lacey, I'd love to hear if you have any thoughts on this, and then also you can transition to the next question. Thank you.
Thank you, Bruce, and everyone. That's really well put, Sedem and Bruce. And I think just echoing what everyone said, it begins with our own inner work, and that involves the reflection of ourselves and our work and what we do daily in global health. And this relates to the next group of questions. I'm going to pull a few together here because they're very similar. Josh asks, what do you think is the first step for global health organizations to realign programs with compassion? And a couple of the other questions that relate with that, what is the first step? How do we do this daily? How can we begin the compassion revolution with small things on a daily basis? And I want to point out, we had a comment from Fatia Kiange who asked the question but poses an answer. Is it not time to rethink terminologies in global health, such as beneficiaries, as that already takes away the power of the grassroots? So that's a bigger question, but let's try and give our audience some concrete, how can we begin to do this? What are the next steps?
Lacey, happy to jump in on this one. Great questions. Sure that these responses are inadequate, but I think one of the things that I'm really glad people are asking is the action, right? So first point is that there is, and this is reassuring to oneself, is that there is always a first step that one can take. So again, coming back to those different levels, if the first step is acknowledging the necessity for compassion, and that itself would be a real bit of progress. And being able to speak about compassion with those that are not convinced about its importance is an important first step. So in all of the institutions that we're in, and in all of the different settings that we're working in, we recognize that there is intense pressure. And as we heard earlier, compassion is no easy task. So being able to advocate for its importance, equipping ourselves with the tools that are required to act, sharing those tools and approaches so that we can cascade the effect around compassion, that in my mind, it would be an important first step. Bringing it on the agenda to be able to discuss it is certainly a first step that we haven't taken in many places. And I think we have to be honest about that. One additional point on the terminology side, absolutely, it is really important to think through how we use certain terms and what that means to people that are listening to those terms. Often the more silent members of a group are the ones that are listening and not speaking related to those terms. That comes back to those power issues that we were discussing earlier. Lots of things to unpack there, Lacey.
Thank you. David or Sedem, would you like to address any of that?
Sedem, please go ahead if you'd like. Yeah.
Sure, thank you. So I definitely agree with what calls to action that people can take in their immediate environments. And sometimes at work, it includes just having the space or creating the space to understand your employees, or to allow them to share some of their frustrations, or to allow them to communicate to you how their working style is, so that you can create an environment that meets people where they're at. We talked a lot about this in the compassionate leadership training course, and how we can cultivate compassion in our daily lives. And sometimes that's just as simple as creating the space for it. Sometimes we're all so busy, especially now that we're all online. And we need to make sure that we are having that time. For instance, at FACE, in our weekly meetings, we always start with a checkup on how everybody's doing. And that may be something that seems really trivial, but in the long run, what it does is it creates a vision for all of us as the employees, and it gives us a purpose. Okay, it gives us that value, like we're being appreciated for the work that we are producing. And so that's one way that you can start, by just simply creating the space in your immediate environment. And another way to start is by asking questions. When we started doing this research on decolonizing global health, we didn't even ask the people that were experiencing the consequences of colonialism, people that are living in formerly colonized countries. And so when we asked them about what their thoughts were, then they came and told us, well, we're not even talking about it as decolonization. How we're talking about it is, this is simply the challenges we're facing living in a low resource setting. And this is how we try to troubleshoot those challenges and still complete our jobs. And so having that ask was able to break that barrier of knowledge, misinformation, and breaking that barrier allowed us to understand where different people, different perspectives on how to come up with a solution for this issue. And so that's two simple ways: by simply creating the space and by asking how, because we can all come together and develop a solution once there's multiple minds at work.
If I could just build on what Sedem just said, I would suggest three sort of possible ways to move forward. One is, as Sedem has said, listening. We think we have the solutions before we even ask what the question is or what the problem is. So having the humility to listen, I think, is really important. And that's an act itself, listening. It's not just passive. The second would be to recognize that as human beings, we all suffer. We don't need to identify as the saviors. In fact, that gets in the way of global health, and it gets in the way of relationship. Recognizing our own suffering and attending to it is actually an act of generosity for others, and enables us to embody compassion for others more effectively. And then the third point, I think, is that we often feel in global health that it's up to us to solve problems, and we can become emotionally isolated, even from our colleagues. So recognizing that this is something we need each other for, and this is a shared endeavor. Global health is a team sport. Even the Good Samaritan did not take care of the man laying by the side of the road himself. He left the man with the innkeeper to continue that care. So we all need each other in this, and recognizing that we have our own limitations and we depend on the support of our colleagues and the people who we're working with is an important step towards compassionate revolution.
Thank you. Thank you all for those thoughtful remarks on that tough question. There's a question that gets a little more specific about how do donors help advance this compassion revolution in global health? I have a thought from some work I'm doing with the Donor Association, but I'd love to hear from all of you first. So how do the donors help with this? There's a related question, I think it's related, in the chat box, not in the Q&A. And if I'm translating the words here correctly, it's can you address the struggle of the funding that supports the scaffolding of accountability? So the need for accountability versus the amount that actually goes to the people who are doing the work on the ground in these countries we're actually trying to help. So maybe both of those, because that's related to the donors as well. Anyone want to take a shot at that first?
Bruce, if I may, that's a really important question. Again, an unsatisfactory answer here, but it does behoove us to make the case for resources to be allocated based on a compassion lens. Now, if that were the case, let's imagine what that might look like. And let's also remind ourselves that it's really important to be accountable for any resources that are spent. Every single penny, every cent, every rupee needs to be accounted for. But if that's accounted for based on number of products, number of encounters, numbers only, which are all very important, don't get me wrong, there's no mechanism to understand how the environment in terms of compassion was. There's something missing. And I think that goes back to David's point in that there can be a bit of a vacuum that emerges in the global health scaffolding that doesn't take into account how a human being is considering a fellow human being. And that warrants deeper academic exploration. So for those that are on this call, of course, there are a lot of academics that are on this call for obvious reasons. That warrants exploration. How does one do that in real terms? Could there be potentially some prototype resource allocations that consider compassion within the DNA of that particular proposal? What would that look like? It could take us in a very different way, but that's where compassion revolutionaries can come in.
David or Sedem?
I think it's a key question, and I think it warrants a lot more thought and conversation with donors. Particularly government donors are on often a one-year funding cycle. Foundations have fads and trends, and they go in and out of priorities, and that creates a lot of challenges. So I think this is a fundamental conversation, not only for philanthropy and foundations, but also for governments that run public health programs. And it cuts across both the public and private sector. I will say that we have a lot of examples where leaders, compassionate leaders, have been able to shift policies to make a difference. So I don't think there's a quick or easy answer to this, but clearly the role of leadership at the very top of these foundations is where significant organizational change can take place. And it would be wonderful to engage some of the leading foundations in this type of conversation at a greater level of depth than we've had so far.
Yeah, thank you. Sedem, we can move on to the next questions. Then I'd just like to say, I think that those are really great insights, and just from a couple of personal experience and relating back to the earlier story, in the perspective of CHA, we often use other industries when we're doing examples, so it doesn't feel like we're blaming our doctors who are going and doing something. So we have some stories about farming or orchards and apple trees that we use to, and the only complaint we get about those is the people that work in agriculture say we're too close to what actually happens also. But I like to say that if you're in an agricultural project, you account for all the tomatoes that get planted, but you never know if any tomatoes got to the people that needed them to eat. And I think that's what some of the accountability that we need to move on, and not just accountability for the dollar spent, but is it making a true impact? Also, I know that there is a current research project going on with an association of Catholic donors, really talking about how do we do exactly this? How do we ensure that what we're donating is ethical and pursuing health equity and justice, and not just somebody's passion, which may end up being that pity response instead of that compassionate response. Lacey, I'd just like to ask, do we have time for one quick question for them to answer, and then we can...
Yeah, if you don't mind, I have a question teed up here.
Oh yeah, please.
This, this comes from Stephen, and he asks, how do we add compassion in a robust and memorable way to global health teaching and MPH programs? And I think, we're at a university here, our audience is broad. I, on one hand, want to flip it back to the entire audience, you in the university community here. What can we do? Is it as simple as Sedem said, create space, put it on the agenda, as Sham said. We begin with these little steps daily, but then let's also think bigger. David talked about the bigger picture there too. What else can we do in the university community? And as I think all the panelists talked about, how do we begin building more evidence for this, changing our practices? And so I flip it back to the audience, but I do want to see if any of the panelists have something else to add on that, how we can really build this robustly into global health training programs as we are training the next compassionate leaders in global health. So David, why don't we start with you, since you also have a university affiliation?
I was hoping to hear from Sedem or Shams first while I collected my thoughts, but I'll give it a try. I think there's several things. One is to realize that compassion, there's a whole science of compassion. It's not a soft emotion that one cannot study. In fact, there's very sophisticated neuroscience of compassion now. There's psychologies of compassion, in addition to theologies and philosophies. So this is something that is tractable for academic inquiry and interrogation. What is the impact of compassion training in a global health setting? What impact does it make? We have an idea of this. We have the teachings of our spiritual traditions. There's a lot more scientific inquiry that could help bolster the scientific foundation of our teaching. I also think that introducing the theme of compassion and diving deeply into the mature forms of compassion and some of these near enemies is important. In global health, we are motivated by compassion, but we're not very literate about the near enemies of compassion or its manifestations, or how it can be obscured by some of the biases and the history of colonialism that we have. So I think inquiry into decolonizing global health can emphasize compassion and its distortions as well. I think it can be embedded into global health training. My sense is that young people come into the field of global health motivated by a sense of compassion, wanting to give back, and then they're faced with biostatistics and other things that are, why do they need this? And so making those links between the inner work and the technical skills, I think will help bring alive both compassion, but also those technical skills, and will keep in front of students the why they're there, getting those practical skills to actually be able to make a difference.
Just jumping in here, Lacey, agree with, of course, with everything that David said. 3 quick points in terms of teaching. Basics of compassion. So it starts to be seen exactly as David had said, as a science and not a soft option. Second, actual examples, feeding that in and embedding that within the curricula, examples of how compassion can change things. And one of the ways of doing that would be to examine it at all those different levels that we were talking about. And the third is to make sure that students have access to a set of tools and resources that they can use. So toolbox, the compassion toolbox for the future. Lacey.
Great. So
That's great. Yeah, go ahead.
I'll just quickly add something that I admired about the way that David teaches about global health is he starts by setting intentions with the classroom or with the students that he's teaching. And I think that is very powerful because it makes you think and reflect about why you got into global health, why you're interested in working in this field that doesn't really have that much money. But, why did we choose to be global health practitioners in the first place? And once you set that intention, once you're intentional about, what it is you're looking forward to after your graduation, what it does is it keeps that in the back of your mind. And for me, as a student and both as an intern at FACE, I know that there's a means to an end. Sometimes I don't want to do biostats, but I know that I need to do this and I need to understand this well, because the communities that I am going to be working with in the future rely on me to understand this concept well. And even though right now it sucks, when I get to the community, I'm able to use, sort of the training, the hardcore training that you gain from the classroom translate it into the field, because what's happening is you are being exposed to sort of this tough training, and you enter the field and sometimes you don't always use it. But what happens is it allows you to think critically about coming up with different solutions with the community together. Because what happens is you have people that don't have any clue of what you're talking about in biostats or whatnot, but they have a clue of their lived experience, and they can bring you in and teach you about that. And you're able to learn and listen once you open your mind and once you set those intentions.
Sedem, what a great way to end. I think you just answered another question for all of us, which is, how do we begin this journey? It's by setting the intention to be compassionate and to live that every day. It really reminded me that when I started a company, when I came home to do responsible redistribution of medical equipment and supplies so that people weren't getting junk overseas, that I often had to remind my employees that it wasn't about picking up stuff and sending stuff. It was about, what are we doing that's really impacting those that we're trying to help? We thank you all so much for this session. We'd like to just have you answer one final sort of question in closing. What what do you think you need to do, we need to do, those on the call need to do to keep this compassion revolution going, and any final comments? Sedem, we'll start with you. What do we need to do to keep this going, and how can others, from your perspective, join in this compassion revolution?
Simple, dare to talk about it, dare to lead with compassion.
Awesome. Shams?
Yeah, Bruce, I think one of the things that we need to remember is the world that we're living in and the unifying potential that compassion has. We are living in a devastated world, realistically, but there's a unifying piece here that we shouldn't underestimate. And in order for us to move forward, we need to be able to make the case, and make the case with hard science, and make the case to the ardent skeptic. We need to demonstrate what is possible. And then we finally need to learn with humility, because we've got so much to learn, and we really need to be humble as we come into this revolution.
Thank you so much, Shams. I hear you. You are a compassion revolutionary. I said earlier, I was on several calls a week. I hear you talk about it often, and I surely appreciate the work that you're doing to make this a global movement. David, we'll close with your final thoughts.
Thank you, Bruce. I can't improve on what Sedem and Shams have said. Sedem mentioned courage, daring to continue to speak and step into that space. Shams mentioned humility. I think we need these both, and courage comes from a really grounded sense of humility and connection. And so we need to move forward just really embraced by humility and surrounded by courage, so we can step into that space where sometimes we need to be able to speak alone without backup, perhaps, in certain situations. And so being able to do so with courage and humility, I think will carry us a long way.
Thank you. Lacey, you have closing comments?
I just want to thank you all so much. I don't think I can add to that. I hope the audience today will take what you've heard today, think about what you can begin doing immediately in your own lives, and begin thinking about this larger revolution in compassion and global health. I've dropped my email and Bruce's email into the chat. If you'd like to continue this conversation, please contact us. We're looking for more engagement, and we would love to bring you all into that. As we leave here, I'm going to put up a slide with just some websites of the various organizations we represent and the Center for Compassionate Leadership, which we discussed earlier, and would encourage you to look up future resources. I did want to mention, I forgot this at the beginning, the Task Force for Global Health and WHO are doing these compassion rounds in global health. And the website, I'll put that up on the screen here. I would encourage you to take a look at those as well. There's been some really fantastic conversation on this topic as part of those. So thank you all so much for your time today and your wisdom, and we really look forward to continuing this conversation. Thank you to the Catholic Health Association and to the Task Force for Global Health Focus Area on Compassion and Ethics for helping us put this together today. Thank you.